So good morning. I'm with Jean Fajadet. There's
Bonjour.
also Bruno Farah, Eric Scampar, Minvo, and Vlad Zavik. And we're waiting for the first case of this live presentation. Philippe?
Very good. Good morning, Serge. Good morning, colleagues. My name is Philippe L'Allier. I'm the director of the Cath Lab at the Montreal Heart Institute. I would like to extend to you a very warm welcome to our Cath Labs and to this meeting. We've been preparing this live sessions for a very long time. And I would like to first and foremost tell you that we have strict rules when we do these live cases. We reconvene every year and we discuss whether live cases are appropriate and whether they are necessary to achieve our academic goals, and we think as of now that they are. So we've carefully selected patients, we obey strict rules, and we have this consensus that was published in 2010 that we still obey by, and we carefully select the patients, as I mentioned before, on the basis of their academic values of the interventions we want to make. These cases are meant to reflect what we do in daily practice. Of course, they are challenging cases. We do not expect our teams to do things we don't do every day. So please bear with us, and hopefully you will find these cases also interesting and the discussions particularly insightful, because we have experts on the panels and in the audience, and I would like again to thank everyone for showing up today. So the live demonstration for this morning, the first live case, the objectives are the following. We would like to discuss how we classify multivessel disease on the basis of FFR when we can perform this FFR during the diagnostic procedure. Second, we would like to showcase how this particular patient benefited from a heart team discussion, and I mean true heart team discussion that is offline, because we think in this particular case it was necessary. And finally, we would like to discuss with you how we would like to treat this very long lesion in a young patient. So here's the Cath Lab team. I will have the pleasure of working today with Marc Jolicoeur. The personnel is listed here, and I would like again to thank all of the Cath Lab personnel at the Heart Institute who have been extremely supportive over the last 24 years, and hopefully for the next years to come. So without further delay, I would like to present you our patient. He's a 49-year-old social worker. He has a very strong family history of premature CAD. He has hypertension, dyslipidemia. He is non-diabetic. Patient presented with progressive symptoms, classified as unstable angina, with negative troponins and normal rest ECG. The patient underwent a perfusion scan, which showed a very high-risk result with LV dilatation, anterior and lateral ischemia, and an LV ejection fraction that was normal at 60%. Patient was referred to cath with the intent to revascularize. So maybe we can show the diagnostic angiogram. So the first, we will show you the right coronary artery, which showed a distal lesion that is intermediate. This lesion was actually quantified at about 40%, 40-50% by angiography. We thought that this vessel was large enough that we could actually do an FFR, and we did during the diagnostic procedure, and that actually showed a 0.83 result. Therefore, we said that this lesion did not need to be revascularized up front. You can also see and appreciate on this view the collaterals to the circumflex, and the circumflex has a very small bed in light of this very large RCA. So this very small distal bed was not judged to be revascularizable either by surgery or by PCI, and I will show you the left system now. Peux-tu montrer la prochaine diapo? So here's the long left main. We have a totally occluded circumflex that is proximal but small bed, as we saw from collaterals. And we have a complex and at least tortuous bend, severe bend, and moderately calcified LED. Prochaine vue. Tandem lesion, moderate size diagonal branches. Prochaine incidence. Here's to appreciate best the proximal bend. Okay, so let's come back to the slides now to tell you what we expect to do with this patient. So can we see the slides, please? Okay, so the clinical presentation for this patient, again, is now not a 3-vessel disease, but a functional 2-vessel disease. And as I mentioned before, the heart team decided that technically only the LAD could be revascularized, and there was at least equipoise or maybe favorable to PCI, and PCI was selected by the patient and the heart team in some regards. So the planned strategy here is to do an LAD PCI with 2 overlapping BRS. This is a young patient, long lesion, LAD, no major bifurcation, but the expected difficulties are severe bent proximal, at least moderate calcification, and if we cannot negotiate the proximal calcifications and bends, we will go revert to a metal stent strategy, which we're going to be a drug-eluting stent in this situation. The material we're going to use is good support. We didn't go for the 8 French, we went for the radial 6 French. We went with an extra support wire. We will use a guide liner should we need to do so. Non-compliant balloons for both pre and post dilatation. 2 absorbed BVS have been selected and are waiting in the wings. Stent enhancement technology, clear stent for the overlap. Online QCA for sizing, including ample use of intracoronary nitroglycerin. And we're not planning on using OCT only as a bailout if we need to do. So I will let Marc Jolicoeur discuss with you what we have done already offline before we come in.
All right, so we actually ended up using a 3.5 because the 4.0 was too long. So if we can see the actual QCA here, you can appreciate the parameters. It's obviously a very tortuous proximal lesion. There's a mid lesion in front of the 2 diagonals, and there's a smaller lesion more distally. If we can show the first balloon dilation, please. So we ended up using a very stiff wire because we wanted to be sure to be able to easily cross the bend. The problem is that this wire combined with balloon ended up causing a accordion effect with no flow. So we immediately turned ourselves up and dilated this gentleman with the 2.5/12 balloon, as you can appreciate here. And more proximally in the proximity right at the bend and over calcification, we ended up also dilating with the 3.0/12 balloons to make sure that the tragic would be a smooth ride. Now, because we were using bulkier BVS, we thought it might be a good idea to use a cutter balloon in the proximity. So because the cutting balloon kind of mimics the bulk of the BVS, precisely what we did. So we dilated proximally with a good results. And we're going to show you the final result here. Well, not the final result, but the result we're at now, which is a nicely controlled dissection in the middle AD that will hopefully, we think, allow passage of our BVS more distally. So we're going to start, yeah.
Yeah, so one other strategy we think we need to use, because we had difficulties pre-dilating and so on, the non-compliant balloon was not open completely. We used a cutting balloon, and we had a reasonable result that we think we can still use BVS. Because it was so difficult, we're going to try to use a guide liner to help up front because of these difficulties. Because, of course, we're planning on using a 2.5/28 BVS distally. We're using 6 French system and a 6 French guide liner. We will try to preload the BVS into the guide liner before we actually put it in the guiding catheter, because we think it is much easier to do this, and we think we're going to be more successful if we can do that. And then we'll see whether it fits or doesn't fit, because theoretically we need a larger guide liner. So here's the BVS itself. We can just reopen this. The way to use this is to put your finger on the tip, slide the yellow part by holding this, make sure the plastic is open, and then remove the BVS without pulling on it. So we have already preloaded the guide liner on the wire. We just will load the BVS onto the wire and then into the guide liner on the table. Of course, very importantly, it is crucial that we don't put air in the system. So we will use a syringe. We will try as much as possible to fill the guide liner. And then we will slide this inside the guide liner, see if it's going to fit. So it slides in nicely.
So it's a 2.5 by 18.
2.5 by 28.
28, sorry.
So it goes in nicely. We're going to bring it all the way close to the end.
So it's out.
And then we'll put it back inside, okay? So we will hold this together, and then Marc will eventually advance this into the guiding catheter. Make sure it bleeds back, as much as we can. We will add some water in here to make sure it's filled as much as we can. And then we will go in with this system. I'm holding up the wire, Marc. Okay.
Here we go.
Slowly, again, because it's bulky system. We want to make sure there's no air that goes in as we push in. And then we will try to advance this as far as we can before we go.
So Philippe, it's Eric. You're obviously demonstrating a very thoughtful pre-planned strategy with the uploading in a smaller guideliner. Have you used a 7 and 8 in situations where you...
Yeah. Yes, we have. Of course, it's easier. But obviously, in this particular case, we hadn't planned so much difficulties negotiating the proximal bend. So we had already the 6 French system in place. And to be fully honest, in most circumstances, we use the preload technique in a 6 French guideliner. Although it is suggested we don't do this by some people, but we've been successful at doing this beforehand.
Je vais montrer si le stent est encore là.
So, Philippe, it's Minvo here. Just
Yes,
another
hi.
question on that same line in terms of the guideliner or guidezilla, because I find that using the bigger guideliner and so forth is better for retrograde reverse cart because you're trying to get into the antegrade guide. For delivering stents, I find that if you use a 5 French guideliner, it's better to advance it more distally. It's easier. So, 2 questions is, 1, with your BVS, would it fit in the 5 French guideliner?
No.
And 2, have you considered also using the guidezilla just because the internal diameter is bigger with the guidezilla, and that might make it easier?
Okay, tire la table un peu vers moi.
So I don't think it would fit in a 5 French. Already in a 6 French, it's fairly tight. As you could see, of course, the 2.5 millimeter BVS actually went in fairly easy, although it's not supposed to, but it does. Marc has just advanced it nicely past the calcifications, and I think he's now going to advance the BVS through this guideliner distally.
So it's there's some resistance right at here. So we'll do a little test here. Let me close first. Okay. All right, so I think it will make it through.
Peut-être avancer le guide.
What?
We're all pushing with you.
Please
What
do
wire
by all
do you have
means.
in there?
Pardon me?
What is the guide wire
It
that
is
you have?
it is an extra sport.
Test.
Okay.
Extra sport is pretty much the stiffest wire we have on the table, on the shelf. It has advantages and disadvantages.
Vraiment mon guiding,
Do you push differently with the BVS versus the DES?
Yeah, I don't, to be honest. I like the slow, steady push all the time, but that's what I prefer.
So it's not going that easy. So what we're going to try here is give more strength to my proximal guiding, and then I'll try to advance even further my guideliner to see if it will be of any help.
It will be interesting. If it doesn't go, we will need to further pre-dilate this portion. Of course, we have been doing this a couple of minutes ago, so maybe there's some moderate recoil. But if it's the case, it will be interesting because we'll need to remove the guideliner and the BVS altogether, and possibly we will see whether we can reuse this BVS or we cannot.
All right, so you see my guiding, my guider coming out.
I have the sense that this is quite difficult and that the lesion probably isn't prepared well enough. And even if you get this BVS down, you're going to have trouble deploying it optimally. So I think you need to do more preparation here.
Because we have, to be honest, we have pre-dilated to 24 atmospheres with a very well open balloon. So we will do it again, but we think that pre-dilatation might be subject to some recoil. But we'll show you, maybe we went a little bit fast earlier, but we really carefully pre-dilated.
Maybe a cutting balloon or an angiosculpt in that spot would be helpful.
Tu l'as retiré complètement?
Non, mais là, j'ai pas de ciné. Est-ce que je vais faire un test ici? Est-ce qu'on peut mettre...
Fascopie.
Test. I agree that it's there's a need for more preparation here. And you see the flow is kind of slow, so we're not going to...
I think you need to bring back the system together.
Yeah. So we're going to bring it back very slowly.
On va prendre le 3-0-12,
So,
s'il vous plaît.
Philippe, what did you use to prepare the lesion, to crack the lesion
So
before?
distally, we used the 2.5 non-compliant balloon to 24 atmospheres, which was very well open. We specifically looked at it in 2 different projections. This is always what we do. And in 2 different projections, it showed a very well open balloon.
Je vais prendre un 2,75 par 12 non compliants, s'il vous plaît.
And therefore, this is, and we do this for every single segment of the vessel. Whenever we inflate, we take 2 different projections to make sure it's well open.
And also your wire is an extra support wire?
It is, of course, it's very long left main, so therefore the support might be a little bit more complicated, but nevertheless, we decided up front that we thought we were going to have difficulties bringing equipment down.
Philippe?
Yep.
It's Jean-François. Sometimes you can try to use a body wire outside of the guide liner.
Yeah,
and,
good point.
Try to slide. The only problem is that you have to retrieve your guide liner to put your body wire.
Yes, and I think in a
guide
6
liner, a body wire, and a BVS are going to be difficult.
No, I mean
That's gonna be very
the body wire is outside the guide liner. It's in
Right.
the catheter.
But it's very tight. I've tried this a couple of times, and
So it's not
with this Cordis system, I think it's a little bit tight.
Philippe, it's Benoit at
Yes.
Dano. Have you considered wiggle wire rather than the extra stiff wire?
We have it, but we don't typically use it for deployment. We like to use it to recross.
Yeah, cross tough lesions.
But
Test here. I think here, Philippe?
Yeah.
Okay. All right, so we're going to take it right at
so
the...
it's a 275 by 12 non-compliant, right? C'est un... Okay.
So a little smaller. You can still appreciate the waist. We're about, I think, 20 some atmospheres.
What is surprising here is that, in fact, the guide liner solved the problem of the calcified proximal lesions.
Yeah.
And it's distally that you have some difficulty.
Yes, that's why we need to do live cases, huh?
But our dissection plan stopped right at there where the stent stopped, so it's not surprising. So we're going to send it. Oh, sorry. Yeah. All right, down.
C'est un petit peu plus loin, toi.
So let's see where we are. Test, Philippe. On va juste...
Plus loin, toi.
Passe juste à la branche. Tire un peu vers moi, Rachel. OK, merci. Test ici. OK, hop.
Tu retires une petite affaire.
Retire une touche. OK, c'est bon. Perhaps while we were working, if Claude, you can show the dissection, the very final angiogram that we took before we came live. So we really thought we made a decent effort at preparing the lesion. Look at the dissection at there. So we thought we had it, to be honest. So it's always...
What's the size of the balloon now?
It's a 275 by 12 non-compliant balloon inflated to
275/12.
Inflated to 24. Now we just need to decide now whether we're going to use the same BVS or whether we need to change to something else.
I think it's decent to give it a shot again.
So there's a comment from the audience about switching for a DES because of...
Absolutely, we could do this for sure. We just are going to do this if we just cannot, but we would just like to give it a second try. And then, of course, this is our revert plan, and we totally agree with this. And we're prepared for this if we need to.
So experience from the panel using BVS, the preparation of the lesion is different, or we know Jean used BVS?
I think it's an excellent demonstration of the need for an aggressive predilatation of the lesion using NC balloon.
On va revenir à 40 pour le push.
Whatever the quality of the support, In this case, I'm sure that with Bruno, we will use a 6 French transradial approach. You know, it's a different way, but you could use 8 French with the guideliner. But at the end, even with good support, the maximum support using even the guideliner, the key is the quality of the predilatation. And that's the key. And it's a totally different way of treatment when we are using bioresorbable scaffold compared to what we are using now since decades with drug-eluting stent, particularly the new generation with very low-profile DES. In fact, the key is to really break the artery. You have to be aggressive, do the dissection, and then treat it. And so, really, it's totally different way of working with the balloon. And this is really a perfect demonstration that even with an optimal support, the key is the quality of the predilatation.
So a question and a suggestion. Are you using the same BVS?
Yes, we are.
Okay, so disregarding the company's suggestion that we should not do a second attempt with the same device.
It's within 5 minutes, we think it's okay.
And it didn't come out it didn't see the wall.
Okay, very well. If it doesn't go, one potential option would be to switch or put a wiggle wire, because the boxes of the BVS may just be buckling against a calcification spicle that you can't move away.
Tu vois mon guiding?
Interesting.
All right, so what I'm going to do now is trying to bring further my guideliner really at the calcification and see what we get here. All right, so I can tell you that there's a lot of tension in this system. So my guiding is totally out now.
Okay, so there is obviously some kind of calcium spicule that we can't appreciate by angio. And again, we will give it a try with possibly changing the wire as was suggested, maybe leaving the first wire in place while we try to rewire, maybe with a wiggle wire or with a buddy wire. But again, the buddy wire I don't think is going to fit just now with the guideliner in place. So it's already difficult to advance the guideliner in the curvatures.
Right, and if that doesn't go, it will be a drug-eluting stent.
What was the pressure with the balloon?
Wiggle 24 wiggle wire. W-I-G-G-L-E.
Do you feel any resistance when you advance the balloon? Because some it's an indication that there is something that is remaining at this level.
To be honest, there was no resistance with this balloon.
Okay. Moment mon guiding, Rachel.
It appears there's a lot of calcification. I agree with needing to optimize that lesion at this point in time. What I would do, and I strongly advocating, preemptively performing rotablation in these lesions. If you think you have some calcium, usually we don't wait for balloon uncrossable, undilatable. And despite the fact that you have dissections in your proximal LAD, we've shown that it's safe. It's been done and it's safe. And a lot of times we will, perform rotablator even within the subintimal space. And it's not unreasonable to, consider using rotablator if you really want to.
So what do you think it is? So spiral dissection or?
Or maybe also some spasm or due to the
it's because you have the proximal dissection. If you continue to inject contrast antegrally, you're just going to propagate. If the patient's hemodynamic is stable, I would just not inject antegrally anymore.
That's a good point. So I think what's best for the patient at this moment is to go with a good old drug-eluting stent.
Passe-moi le 2530 Resolute, s'il vous plaît. Peux-tu me donner ça, Ghislain, s'il te plaît, le 2530 Resolute?
Your ACTs okay?
Yes, yeah.
Okay.
We had a 315 ACT before we started, so we think this is okay.
That's a problem that we see sometimes when you try to push your guide liner hard in tough lesions, and you can end up with a dissection because of the guide liner and not related to your balloon angioplasty.
Un petit coup de scotty, Marc.
Would you consider using a second wire?
Yes,
to go?
it's a good idea. So we, est-ce que vous nous préparer un pilote 50, s'il vous plaît?
Scopy.
I think one other option for the distal image could be air embolism with the guide liner and the BVS you had.
You think air?
Well,
I considered it. It's a good point because we haven't seen any, I don't see a clear spiral dissection.
I don't see any dissection, after the second diagonal, and it ends abruptly.
Comment tu peux négocier ça?
And it happened after the second attempt with the BVS inside the guide liner.
Juste comme on avait prévu.
There's a question or a comment from
On va donner
the
Fontanelle
audience.
50, s'il vous plaît.
Hi guys, we don't want to bother you too much, it's dawn, but I think Benoit's point is good. Look at the second diagonal, it's also, there's an occlusion there, and so it's either thrombus or air that has gone into multiple arteries.
So if it's air, we would know it soon enough, and then if it's clot, we should start
We will recheck the ACT after we put in the stent. Nettoie le guide, s'il te plaît, Marc.
Est-ce qu'on peut mettre la l'IVA native en référence et non pas la l'IVA disséquée?
So now we will bring down a metallic stent and put it where we thought we were going to need to put it initially to see if there's a dissection and possibly if it's air embolization. The diagonal, as mentioned before, was... The distal embolization is now potentially an option with regards to the diagonal being abruptly closed. So we will give a little bit more nitroglycerin. Pressure is not too high, but not too low either, so we'll give a little bit of it. So despite the fact that we paid really good attention to not pushing, you need to realize this is a very bulky system. And unfortunately, this is my... And if it's air embolization, we are fortunate, to be honest.
So I think we'll need a body wire here.
One option would be to go back with the guide liner, use a balloon where you post-dilate, and try to bring as you deflate the balloon, bring the guide liner distal to the lesion. This way you're sure as that your stent is going to be able to pass this pen.
Peux-tu mettre le guide tellement quelque part d'autre?
Je vais prendre un deuxième guide.
Tu veux retirer le ballon?
Ouais, je vais retirer la stent.
So Philippe, what we'll do, we'll look at are you planning to, okay, you'll change your stance?
Yeah, we're going to go with the body wire.
Okay, maybe a last and we'll go to the other room, but we'll be back with you for sure. But there's a question from the audience.
Philippe, it's Stéphane here.
We're not planning on going retrograde, Stéphane.
Yeah, I know that. But there are simple anti-grade solution. I would not refrain from considering dropping your stent, even if the stent doesn't go further down. Just get rid of this tortuosity proximally, and I suspect you'll be able to deliver stents more distally afterward, and also make sure that the wire is distal enough. But I would not dogmatically think of treating from distal to proximal in that case, because of this huge tortuosity, and you build up some resistance when pushing through it. So you might want to just get rid of this first.
Okay, so just a few seconds, Philippe, what are you planning to do in the next minutes? And we'll go to the other room.
So body wire first. If it doesn't work, we're going to go with the guide liner. going to break down the stent, put it where we think it was. Hopefully, we will take another angio and see the distal bed through the air embolization being reabsorbed. At least we will have at least one bioresorbable material in the artery. But yeah.
Okay, perfect. So thank you, and we'll be back. And we'll go to the other room with Reda Ibrahim and Anita Asgar for another case.
You're welcome.
I would say different case. Anita, Reda?
Hi, welcome everyone. Welcome in the hybrid room here at the Montreal Heart Institute. I will let Anita present what's the plan here.
So welcome. We're going to be doing a left atrial appendage occlusion this morning. So these are our disclosures. I don't know if you can see the slides. So today our learning objectives for this case is to discuss who to refer for left atrial appendage occlusion. We're going to review the procedure with you step by step, and we're going to discuss how to treat these patients before, during, and after the procedure. So our patient is a 78-year-old male. He lives at home with his wife. He's got a history of dyslipidemia, a AAA with previous surgical repair, a left hip replacement. He's in permanent atrial fibrillation, and he had a CHADS and CHADS-VASc has blood score, as you can see, and he was on heparin previously until he had an episode of cerebral bleeding last year. He was referred in December for an occlusion of the LAA, but pre-procedural transesophageal echo did show a left atrial appendage thrombus. So this was his initial TEE, and as you can see, there's evidence of perhaps a small thrombus there. At the time, the potential options were to treat only with antiplatelet therapy or try re-anticoagulation with the more novel anticoagulants with a history of previous cerebral bleeding, thought to be less of a risk with bleeding with these newer agents, or surgery for this patient. And so the choice that was made was to re-anticoagulate this patient with apixaban, but also to consider occlusion of the left atrial appendage if there was evidence of thrombus resolution. So he had a repeat TEE on the 20th of May, and we can see very nicely that there is no thrombus in the left atrial appendage. The decision was made to close the left atrial appendage. So I'll let Reda talk to you a little bit about the morphologies of left atrial appendage.
So as you can see, there's a lot of variation concerning left atrial appendage, but there's four main morphologies, and they are well shown here: the windsock, the cactus, the chicken wing, and the cauliflower. In this case, it's more a windsock appendage, which is the third most common form of appendage. Next slide, please. Oh, it's myself, sorry. And it's just to show that the windsock, they are more at risk of further thrombus formation and embolic event than the chicken wing, for example. And the velocity in this appendage, they were very, very low. This is back in May, showing that this patient is at very high risk of recurrent thrombus. So the strategy at this point now, like today, it's to either continue the anticoagulation, to consider LA occlusion, and if we do LA occlusion, I guess it's always which device. I just want to remember that it's a class 2B indication, left atrial appendage occlusion in patient at high risk of bleeding. This is from the most recent European guidelines in 2012. There's two established intracardiac devices for LA occlusion, the Watchman by Boston Scientific and the Emplaster cardiac plug/amulet, which is the second generation from St. Jude Medical. They are both CE marked since a long time, but only the Watchman is FDA approved, and this is since March 2015. Both devices, they are available under special access program for compassionate use, and the rationale is really to try to exclude the appendage, the region where typically 90% of the thrombus are forming in patients with non-valvular AFib, like this patient. So this is the team. We'll go fast on this, and we are today in the hybrid room. Patient is under general anesthesia. TE guidance will be made by Dr. Arsène Basmadjian. We're using 3D echo. Femoral vein access was performed already. Vein was pre-closed with a per-close. We did the transeptal because we had some issue here that we will explain you well. And saying that, I will let Dr. Basmadjian explain what happened so far.
Thank you, Rita. Good morning, everyone. What I'll go through is a few images that we took a little short while ago. All these procedures are done under TE guidance. As you can see here, we're sliding through to a 4-chamber view.
And,
left atrium here.
Just 2 seconds. We don't see the echo. Can we show the echo, please?
So Rita, let me know as soon as you have it.
Okay, yeah, we have the echo now.
Okay, great. So we're in the 4-chamber view here, kind of sliding in and out of it. So all these procedures are done under TE guidance. You can see the left atrium here, right atrium, the tricuspid valve comes in and out of the view, and the mitral valve. You see, important things just to note, we have good left ventricular function and the absence of a pericardial effusion, which is very important to note at the beginning of the procedure. Now, I don't know how well this shows on the giant screen, but there's a lot of smoke in this left atrium. And as you know, smoking is bad for you. Here we have the left atrial appendage, and the left upper pulmonary vein is here. Now, what we didn't like to see this morning was what wasn't shown on the last echocardiogram on the transesophageal, which had disappeared, is there's a lot of smoke going on here and a lot of sludge. So we'll show this in an X-plane view, which the 3D probe permits us to do. So you have more of about a 60-degree view here and approximately a 120-degree view here. So what we have is a windsock appearance, but also all these appendages have a lot of trabeculations. And what I don't like is what's going on here, and I'll explain to you why. Again, a lot of sludge. We do some pulse wave Doppler, which shows very low velocities. Normal velocities should be above 40 centimeters per second, in fact about 50 or 60. And when it's below 40, we have a risk of clot, definitely below 20. It's a high risk of clot or thromboembolism. Little 3D image showing here the ostium of the left atrial appendage, which is clear and open, and at least about 1 to 2 centimeters deep. There doesn't seem to be any thrombus. What we did was we used Definity, which is a contrast agent, and we just gave 0.2 milliliters of Definity with about a 5 to 10 cc saline flush. And what we show here is the contrast agent that is pacifying the left atrium, but it's very slow going into the left atrial appendage. And here's a stop frame showing that the Definity, the contrast agent, completely fills the left atrial appendage except the tip here. So this is highly suspicious, highly suspect of a left atrial appendage clot. If we measure, which is going to be important for guiding and sizing particularly, we have measurements that vary between 2.1 and 2.6. I went a little bit wide here, maybe 2.5 centimeters. And we have a safe depth. When I say safe, that will be part of the discussion following, about 19 millimeters. And the clot, or what we suspect is a clot, measures about 11 millimeters. Finally, we did the transeptal puncture with TE guidance. We want to be, this is a bicaval view. Actually, we see the superior vena cava here. So we're in a we want to be in a mid to low position. And here we're in a posterior position with your aortic valve and your aorta being up here. And this is just basically, I'll let the cath team discuss this a little bit more. So this is just showing the puncture. And finally, since we're going to be needing some TE guidance during this procedure, this is just showing that the guiding is in good position right at the ostium of the left atrial appendage, and we don't want to go too deep here for obvious reasons. So I'll switch the mic back to Anita and to Reda.
So I guess there was a lot of discussion around this case. So we were not expecting to find again a thrombus in the appendage. The patient was kept on apixaban until yesterday. And a thrombus in the appendage, it's in theory a contraindication for this procedure. And so we don't want to do things that we don't do on a regular basis. But this patient is obviously a very high risk because he had that thrombus and a clot formation under apixaban. And it's why we are potentially ready here to close this appendage. But maybe not with the device that we are planning to use. We were planning to use the Watchman today, a device that it's a good for anatomy like this one, a windsock appendage. But it requires some depth to put the Watchman because typically the Watchman is as long as large. So it requires to deploy the device from the distal part of the appendage to the proximal part. So that was not an option here. So the other option is to consider to close with the Amplatzer, which is another device that we typically deploy more on the proximal portion of the appendage. Can we recuperate here the slide? Yeah, and I just want to show you what's the difference between the two devices, just to understand well what's the point. So this is the two devices that we have, and the implanter or device, the cardiac plug or the amulet, the second generation device, it's made by two components, a lobe that you deploy in the landing zone, but not at the distal part of the appendage, and a disc that will cover eventually the structure. So the only option here, if we want to close, is the implanter, but it doesn't mean that we should do this. We should consider the risk and benefit of doing that on this patient. I can show you maybe some flow or some angio that we just perform using the guiding catheter. We typically like to do two different views, RAO cranial view. And this is showing typically better the proximal portion of the appendage. Of course, here we were very careful to not inject too hard to avoid embolization, to try to prevent the embolization of the thrombus. I think we can suspect well here the thrombus at the distal part of the appendage. There's some stagnation of contrast that you see well. And we see that we have some room, at least proximally, to work. And next image. And this is now this is the areocranial view. Sorry, the other one was the areocaudal view, showing more the distal part of the appendage. And the next one is the areocranial view, showing more the proximal portion of the appendage. We did some measurement also that we want to correlate with echo. And this is the measurement of the landing zone. X2 is the landing zone. It was roughly 19 millimeter on the caudal view, and on the cranial view, it was a little bit higher than that, 20 millimeters, for an average of, let's say, 19, 20 millimeter. So always we want to use a device that's going to be oversized. And if we want to use the amulet here, which is the implanter, we can consider the 22, but I think it's just borderline. It's not oversized enough. We have now after a 25 millimeter device. So it's open for discussion. What do you think? Should we go ahead?
Reda,
yes.
Just if I understand well, at the previous ETO, there was no thrombus.
Exactly.
Definity was not used at that time.
Yes, it was used actually. It was used. And the images,
used
I don't know if you
also?
could hear me, but the images were, we didn't show the images, but Definity was used, and there was no evidence of that. And I'm the one who did the previous study, so I can attest to it.
And we think that the anticoagulation of the patient was good during that time. There's the
He was compliant. He was on apixaban, and he was compliant with that. So we can only assume that the anticoagulation was sufficient.
So did you face a case like that before? Or?
So no, not yet. We have one patient that we scheduled for appendage occlusion soon with a thrombus in the appendage, a refractory thrombus. Patient cannot be anticoagulated. So we were planning to do a patient pretty much like this one soon. So, but I guess this one will be potentially the first one instead of the patient that we were planning to do.
Okay, maybe we can ask, I know that Bruno Farah has experience with that kind of new technology and new intervention. Bruno, you're doing that type of case. Any comment?
Yeah, I'm not the experience of Reda, but we have done some case, and for the moment we have never closed the appendage when there was a thrombus. So for me, it's difficult to comment because it's a relative contraindication. I know that it has been done sometimes. It's not an absolute, but it's a relative contraindication. I never done it, so I cannot comment of the possibility or not to do it, to be honest.
Okay. So you see, Reda, you're the one with the most experience with Anita, so I don't know what you're planning to do.
So I guess because we feel that we are in very difficult situation, we feel that the anatomy is suitable for appendage occlusion, and we feel that we have some room between the proximal portion of the appendage and the thrombus. We think that we can potentially go ahead, but not with the Watchman in this case, but with the implanter. So I guess we will try that now live and see what's going on.
And just to clarify for you, we did have extensive discussion about what's the best treatment for this patient. And given the fact that he had quite significant cerebral bleed, And now he's at significant risk for an embolic event, given the fact as well that he couldn't take Coumadin, and he developed this on apixaban. We really felt in order to best treat this patient, we would close this device with the safest device possible to minimize any chance that he would embolize. So it's not a decision we've taken lightly, obviously, and we're putting what we think is best for the patient first. And Rada has the most experience with this device, so I think this is the right course of action.
All right, so we have the device here. The device is typically preload, so we cannot show you well the device, but it's preload here in the loader. It's a 14 French delivery sheet, double curve. Loader is, of course, also 14 French. We just flushed the device before to be live, and we are ready to insert this. We can potentially put that on flush. Because we are working in the left atrium, we want to minimize the chance to have air embolism. So we want to flush well the system and remove all the air. I will let my sheet in the left atrium bleed because I don't want to have any thrombus inside. And I will connect this. Je pense que je vais prendre l'autre. Je vais avoir besoin de l'autre connecteur. There's an adapter between the loader and the delivery sheet. And my delivery sheet is not in the appendage, it's at the ostium and appendage, just at the mouth of the appendage. I don't want, of course, to enter the appendage with my delivery sheet. So we are pushing the device. I will show you the fluoro live. So I have the delivery sheet in the left atrium. There's a distal marker at the end. I will open the device in the left atrium and push the device partially open in the appendage.
I'll leave you there.
Okay, very good. So we have the device at the tip of the sheet. I will. Can you see the echo also? Can you show
I'm looking for it right now, yes.
So can remove maybe the macula, maybe show the echo live at the same time? Because this procedure will be largely guided by the echo now because we don't want to inject too much. So I open the distal part of the device. I think I'm in the left upper pulmonary vein.
No, you're good. Here's the left atrial appendage.
I think I'm in the vein.
Hold on. Yes, you are in the vein.
In the vein, huh?
Yep.
So I want to recuperate potentially this.
We'll put that going.
You're up here.
I want to turn. And
can we see the echo instead of the? Yeah. Okay. Very good.
You're up here.
So I guess I lost my position in the.
In the interim, you're in the vein. You see yourself?
Yeah.
Yeah, there you are.
So I need to try to go back in the appendage with my delivery sheet.
Use your left image on the echo.
Yeah. And it's very important to have a good transseptal puncture to be able to reach the appendage well. But let me try to open this again, and I want to drive in the vein.
Yeah. Up here, right there.
It's quite safe to push the distal device like this, the ball, because we don't want to perforate, of course. I'm still in the vein?
Yeah, you're too high. You're up here. Yes, there you see.
So I guess I will need to potentially go back with the delivery sheet in the appendage, because it doesn't seem to go with my device.
In the vein.
In the vein. So you see well that I'm going easily in the left upper pulmonary vein, which is just above the appendage. And I will potentially need to go more distal in the appendage with my delivery sheet to be able to go.
Now you're coming out. You're still over the ligament.
Typically when we pull from the vein, we typically fall in the appendage. In this case, doesn't seem to
there you
happen.
go.
See, now I just felt in the appendage from the left upper pulmonary vein. I have the distal part of my device in the appendage. I will push carefully, don't want to go far.
You're good.
And I can potentially try to expand the device here.
You're a bit too high.
Okay. So at this point, we want too high, you mean?
Yeah, too much into the left atrium, not enough into the appendage.
Okay. So I will push.
Now you're getting into a better position.
So as I said, here we are going to do, typically we like to inject a few times. Here, in this case, I will try to avoid this. We will largely use echo to guide the procedure to try to minimize the risk of embolization.
That's pretty good.
What do you think, Arsène?
That's pretty good right now.
I think we are quite well
now you're good.
inside the appendage.
Yeah.
So at this point, the distal part of the device is open. When we will push on the cable, the device will expand. So the lobe of the device will expand, and the device would tend to jump back at the same time. So the final result will be the fact that the device should be at the same place. So I will ask Anita to push on the cable of this device. It should deploy the lobe. See, the lobe is open, and we will evaluate on echo if it's far enough. Because there's always the possibility to recapture this device. And there's few landmarks. Do you want to comment on the landmark that we are using, Arsène?
Well, actually, in the 60-degree angle, here we have the main landmark we're using is the circumflex artery right here, and the other landmark, it's easy to see, is the Q-tip or the ligament of Marshall. So you're clearly well inside there. That's never an issue. That's rarely an issue. The issue here is going to be if we're going to be deep enough within the left atrial appendage on the 60-degree view. It looks actually pretty good on this view. Where there's a little bit more limitation, or we're really much on the edge here, is on the 120-degree view, where we're definitely deep enough superiorly, but we're just on the edge here when it comes.
So I guess we can potentially recapture, try to redeploy a little bit more distal. We can try to do this.
We're talking angulation and we're talking millimeters.
So we can pull on the cable of this device until we reach the small marker. So pull back, pull, pull. See, there's small marker on the lobe, and you cannot recapture beyond these marker, because if you do this, you can potentially damage the
2-3 millimeters. We're talking about
2-3 millimeters.
Yeah, 2 max probably, because we're near the.
And then
near the tip.
I can try to realign also the device to be in a better axis with the appendage, and we can potentially here.
Okay, that's good.
Push here, I need
Yeah, that's enough, Reda.
Enough? Okay.
Oh, yeah, clearly.
Push here.
Don't want to go any deeper than that.
Okay, very good. So we redeploy more distally.
Oh, that's good.
We are behind the circumflex. Arsène, you can comment on echo.
Yes, absolutely. Right here. There's your circumflex right there. So you're actually very nice here. Sitting nicely here. And actually here, I don't think you want to go any deeper because your clot's right down there and you don't want to. So here you're sitting better. I'm going to put on a bit of color Doppler, or you want to wait to deploy first? We can just use one.
So this is the lobe component of this device. We still need to deploy the disc over the ostium.
Okay, I'll let you do it.
Very good. So let's do this. So at this point, we will unsheath the device. Should open so we will unsheath.
So pull back.
Pull back. It will open the disc. So the lobe, the device was 25 millimeters. So the disc is 7 millimeters larger than the lobe, and it's now deployed here over the ostium of this appendage. So the disc is 7 millimeters larger than the lobe, so 32 millimeters. We definitely want to be sure that we are not compromising the mitral valve.
And you're not. This is actually sitting nicely here.
On peut-tu prendre le 22, s'il vous plaît, le champ de 22?
So far, so good.
So you see this device. We want to appreciate different points to be sure the device will be safely placed in this appendage. We want a good compression of the lobe, which is the internal. I will maybe record this to stop to do the fluoro. So we want a lobe that's going to be well compressed. It seems to be compressed here. We can measure the lobe actually to be sure that it's less than 25, the nominal diameter. We want a good separation between the lobe and the disc. Here it's like minimal, but it's fine. We want a disc that is curve on the ostium, and we want a device that is in line with the appendage, which is the case right now.
So about 22, 23 millimeters there.
Reda, it's Benoit. Do you think your device is large enough?
I think the device is borderline, to be honest, Benoit, because we choose a 25 millimeter device on purpose because the next device after this one is 8, and if you're choosing a device that it's too oversized, it will potentially you will potentially fill all the appendage. So we decide to go on the lower side.
No leak.
And I feel that it's compressed because Arsène, he measured 22. So the device is not fully expanded, meaning that it's compressed enough in the appendage. Typically, we want a device that it's 2 to 4 millimeter oversized. So we are right on for this.
And there's no leak.
So Anita, Reda, it's I would say a wonderful demonstration and maybe a premiere for you with the thrombus in the appendage. If you can conclude in a couple of seconds, I know that the other room is waiting for us to show us the final result.
Can you potentially we can potentially recuperate the slides? We will deliver the take-home message. I think there's a clear role, I think, for an intervention like this one for a patient at high risk of bleeding and patient at high risk of stroke. There's some data supporting that, including randomized trial, including the guidelines, including the fact the FDA approved recently the Watchman. I think we can perform this procedure very safely and very efficiently in some centers of excellence with a decent volume, but also after very good patient selection. So thank you very much for your attention. Anita, thank you for your help.
Thank you.
So I guess we are happy. And thank you, Arsène. Thank you very much.
Pleasure.
So we are with Philippe and Marc.
Okay, so we have been working a lot since we left, and of course Don's diagnosis was the right one. This was air embolization. We gave, of course, nitroglycerin and neosynephrine, which of course took care of the situation. The patient was not so unstable, and we recuperated the distal bed. Of course, that distracted us a little bit, and we decided to go with drug-eluting stents, metallic stents, as opposed to BVS. We think we could have succeeded eventually if we would have kept on working on the issues that we had with regard to discalcification. We were able to advance the guide liner up to the place where we had difficulties advancing the BVS and position distally a metallic stent fairly easily, in fact. So we put in a Resolute 2.5 by 30 and a Resolute 3.0 by 18 more proximal. And we are just going to show you if we can cannulate the left main, which is there is severe tortuosities in the shoulder that's making maneuvering the guiding catheter a little bit difficult. And plus it's a little bit...
So can we see any angio with that?
We're just about to give it to you if we can cannulate. Grande respiration, peut-être.
Prenez une grande respiration, monsieur.
If not, we will show it to you early afternoon. Okay. 10:40, s'il vous plaît.
So what we did is we post-dilated with a 3.25, a 3.0, sorry. Okay, tests.
C'est bon, signé.
So,
on va faire le latéral. Tu peux commenter, Marc.
So to be perfectly honest, we were surprised. As the case progressed, the support became weaker and weaker, and we did realize that we had a huge curve in the upper arm, explaining why it was so difficult. So my guiding was kind of acting inappropriately. So we had to correct that as well. So, Sinead? I think it's a decent result. It was not a dissection, it was air emboli. Yeah.
Congratulations, very good. So did you rewire the LAD before putting your stents?
What we did is that we left the original wire in place and we took care of the hemodynamics first, therefore giving, as we mentioned previously, nitroglycerin plus neosynephrine. And then, of course, we eventually were able to bring down the guide liner more distal than we were able to do initially. And then we brought down the metallic stent, and it went down very easily, even too distal. We brought back the guide liner. We brought back the metallic DES in place and inflated it on the way out. And then as we deflated the stent balloon, we advanced the guide liner on the half-inflated balloon so that it would slide in the distal stent without catching the proximal strut. And we're able to position inside the distal stent the more proximal stent, and eventually post-dilated everything with non-compliant balloons, and to get the result that you see just now.
Précédent.
So even the drug-eluting stent was difficult to position, and you need the, what do you say, the difference between the two technology? Was it?
Well, to be honest, we decided we were able to advance the guide liner more distal than we were able to do when we tried with the BVS. So it's not entirely clear whether we could have brought down the BVS as well as we could. To be fully honest, I think we could have. We were distracted about the clinical instability and the loss of the distal bed on the LAD. So therefore, we decided to go back and take action and act upon this situation. This is the live case scenario where we think we need to take a decision in a split second, and we did. We think, however, that we could have put in a BVS if we would have tried a little bit harder. And for example, if we didn't lose the distal bed, we could have concentrated a little bit more on the BVS portion of this intervention and finalized it. But of course, one really good conclusion might be that if the artery is talking to you, just listen to it. And probably a metallic stent was a good alternative here.
Thank you very much.
Thank you. On va aller surdilater la proximité.
So with this case, we'll conclude this session, and we'll go to the coffee break. But I'd like to ask you to be back at 10:30 sharp. There's 3 different rooms with 3 different presentations. Here there'll be an update on the clinical management of acute coronary syndrome. And there's also 2 presentations in the International 1 room and International 2. One will be tips and tricks, and the last one will be for peripheral, beyond coronary, beyond the heart, talking about large vessel and the aortic involvement. So thank you again for your participation, and see you at 10:30. And I'd like to thank also everybody on the panel for the good comments and the great discussion.